Okay, let's dive into this. Welcome to this explainer. Today, we're taking a highly structured, really deep dive into high-yield clinical psychiatry. Honestly, you can consider this your essential masterclass for passing those incredibly tough board exams, or honestly, just finally wrapping your head around some of the most nuanced diagnostic criteria in the DSM. We are going to tackle three very distinct categories today: delusional disorder, sexual dysfunctions, and paraphilic disorders. And my goal here isn't just to read definitions at you. I want to teach you the exact clinical distinctions that test writers and senior clinicians are going to expect you to know cold. So grab your notebooks, get focused, and let's get started.
So here's our syllabus for today. First, we'll be defining delusional disorder. Second, we'll cover high-yield exam distinctions. Third, understanding sexual dysfunctions. Fourth, paraphilias versus paraphilic disorders. And finally, clinical treatments and interventions.
All right, let's jump right into section 1, defining delusional disorder.
If you are sitting for an exam or, evaluating an actual patient, this is a diagnosis that requires extreme precision. Delusional disorder is characterized by the presence of one or more delusions for 1 month or longer. Now, what's really interesting about this clinical definition is that absolute minimum duration rule, that 1 month cutoff. If it's been less than a month, well, you are looking at something else entirely, like a brief psychotic disorder. Furthermore, it is incredibly critical to note that the patient's functioning is relatively well preserved outside the specific area affected by that delusion. They might hold down a super demanding job or maintain completely normal friendships, all while harboring a profound, fixed false belief. And crucially, they must not meet the full symptom criteria for schizophrenia.
Clinically speaking, we categorize these delusions into specific subtypes, and trust me, you need to be able to spot them quickly in a case vignette. You've got the erotomanic type, where the patient believes someone, often someone of higher status, is secretly in love with them. Then there's the grandiose type, which is characterized by this massively inflated sense of worth, power, or identity. The jealous type involves a fixed, unshakable belief that a partner is being unfaithful. And then we have the persecutory type. Actually, I want you to circle this one in your mind because it is the absolutely most common presentation you're going to see. This is the belief that one is being conspired against, spied on, or harassed. Finally, there's the somatic type, involving bodily functions or sensations like believing you have some bizarre undetectable disease, along with mixed or unspecified types. Etiologically, cognitive theories suggest these actually arise from biased reasoning, kind of like jumping to massive conclusions from super limited evidence rather than the broad neurodevelopmental disruptions we typically see in other psychotic disorders.
Moving right along to section 2, high-yield exam distinctions.
Now that we have the definitions locked down, let's pivot to how you are actually going to be tested on this material. You have to know how to distinguish these conditions from their close diagnostic neighbors using the rule-out diagnostics technique. In psychiatry, knowing what a disorder isn't is honestly just as important as knowing what it is. On one hand, you have delusional disorder. It's delusions only, with relatively intact daily functioning. On the other hand, you have schizophrenia. To formally diagnose delusional disorder, you absolutely must rule out the prominent features of schizophrenia. That means no prominent hallucinations, no disorganized speech, and no negative symptoms, like a flat affect or avolition. The whole exam angle here is almost always going to be about duration and the presence or absence of prominent hallucinations and disorganization. If a test question presents a patient with a 2-month history of a fixed false belief, but hey, they also have prominent auditory hallucinations and highly disorganized speech, you are no longer in delusional disorder territory.
Okay, section 3, understanding sexual dysfunctions.
Let's shift gears a bit and objectively look at the physiological and psychological mechanisms at play here. Sexual dysfunctions are fundamentally disturbances in the sexual response cycle, or pain associated with sex. The DSM organizes these into 4 highly testable, very distinct categories. First up, desire or interest disorders. This includes things like male hypoactive sexual desire disorder or female sexual interest/arousal disorder. Second, we have arousal disorders, with the most commonly tested one being erectile disorder, which is the persistent difficulty in attaining or maintaining an erection. Third are orgasm disorders, which include female orgasmic disorder, as well as delayed or premature ejaculation. And fourth, pain disorders, specifically genitopelvic pain/penetration disorder, which involves significant difficulty, fear, or anxiety regarding vaginal penetration and pelvic pain.
When we conceptually map out the causes or etiologies of these dysfunctions, you're going to notice something pretty quickly. You will barely find a case that is purely one or the other. They almost always combine. You have your physiological factors, things like medical illnesses, medication side effects, or hormonal changes. Then you have psychological factors, such as performance anxiety, a history of trauma, or underlying depression. And finally, relational and sociocultural factors, which encompass things like poor partner communication, rigid sexual scripts, or broader societal stigma. When you're evaluating a case, you absolutely must assess all three of these columns to understand the full clinical picture. It's like a giant puzzle where all the pieces connect.
Next up, Section 4, Paraphilias versus Paraphilic Disorders.
All right, get ready, because this section contains a vital DSM-5-TR diagnostic nuance that board examiners absolutely love to target. Let's objectively list the specific categories of intense, persistent sexual interest covered in the manual. We have voyeuristic disorder, which is observing an unsuspecting person; exhibitionistic disorder, exposing oneself to an unsuspecting person; voyeuristic disorder, touching or rubbing against a non-consenting person; sexual masochism and sadism, where arousal comes from either suffering or inflicting suffering; pedophilic disorder, and let's be absolutely clear here that this involves illegal, non-consensual predatory harm against prepubescent children. The strict clinical criteria states the individual must be at least 16 years old and at least 5 years older than the child. Finally, we have fetishistic disorder, involving non-living objects or non-genital body parts, and transvestic disorder, which involves cross-dressing. So, the crucial point is understanding the major distinction between a mere interest and an actual disorder. This is huge. A paraphilia is simply an unusual sexual interest. The interest itself is not automatically pathologized. It only becomes a paraphilic disorder under two very specific conditions. First, if it causes the person significant clinical distress or impairment in their daily functioning. Or second, if it involves harm, risk of harm, or non-consenting others, such as an exhibitionism, voyeurism, frotcherism, or pedophilia. Think about it. If an individual has a fetishistic interest that causes them absolutely no distress whatsoever, doesn't impair their life, and involves entirely consenting adult partners, it is simply a paraphilia. It is not a diagnosable psychiatric disorder. Seriously, do not let test questions trick you on that nuance.
Finally, Section 5, Clinical Treatments and Interventions.
Let's see how this all builds into our treatment plans, and how clinicians actually go about resolving the distress and impairment caused by these conditions. For delusional disorder, we typically use antipsychotic medications. However, and this is a massive high-yield fact to remember, the response to medication here is often much more limited than in schizophrenia. Why? Because the patient's insight into their delusion is typically very, very poor. Therefore, building a trusting therapeutic alliance and using supportive or cognitive therapy to reduce their distress is absolutely essential before you even try to challenge the delusional content itself. For sexual dysfunctions, treatment often involves sex therapy, such as Masters and Johnson's sensate focus techniques, alongside couples therapy, psychoeducation, and medical interventions like PDE5 inhibitors, such as Viagra, for erectile disorder. For paraphilic disorders, the gold standard is cognitive behavioral therapy. You're really targeting those cognitive distortions and focusing heavily on relapse prevention, especially when non-consenting victims are involved. In severe cases, we might even use pharmacological reduction of the sex drive, using antiandrogens or SSRI antidepressants.
And that brings us to the end of our explainer. So, let me ask you, could you confidently differentiate these disorders on your next exam? After breaking down the exact diagnostic criteria, understanding those absolutely crucial duration rules, and conceptually separating an unusual interest from an actual disorder, I am confident you have the exact framework you need. Keep these diagnostic distinctions front of mind when you review, really remember those distinct rule-out guidelines we talked about, and you are going to be perfectly positioned to ace this material. Thanks so much for learning with me today, and keep that focus sharp.